The month of October was Breast Cancer Awareness Month, a time where the world came together in pain to talk about breast cancer awareness, why it's important for screening. Now, while October may have come and gone, you will agree with me that awareness hasn't stopped, and that's the reason why we are here today to look back at the activities that happened in October, especially in Enugu State, talk about why you should go for screening, and of course the options that are very much available for screening. Now, having said that, good evening and welcome to GYNA Plus. This is where we discuss health issues that affect women and girls in the society. My name is Doris Mayemshishe. This program comes up every Wednesday at 6 p.m. We always have a repeat broadcast on Saturday at 8 p.m. And yes, we have an active YouTube channel, Afia Culture and Lifestyle. There we have loads of health topics that have been handled. So if you have a need to refer back, please do well to visit Afia Culture and Lifestyle. And of course, today, like I mentioned a while ago, we'll be looking at breast cancer. While it's important, more like a post-mortem of what happened in October. And trust me, we have a lot in stock for you. After the break, you're going to meet my guest, such an amazing woman, someone who is an expert in the field. Guess what? There's a lot coming your way, but that will be after the break. Please stay tuned. Welcome back. If you just joined us, you're watching GYNA Plus on Afia Television. This is a time where we talk about health issues that affect women and girls in the society. And this week, we're going to dim a searchlight on cancer, more like looking back at what happened in the month of October from the activities, the screening, and of course, where we can, more information as to how you can live a healthier life and maybe prevent maybe not coming down with cancer, if that's the right word. Once again, my name is Doris Mayemshishe, and I mentioned that we have a very, very, very beautiful woman who's joining us today, an expert in the field, someone who's going to give us the information that we need. And on a normal day, it's not someone you get to see, because you have to pay so much just to see her. I'm talking about Dr. Ngozi Dim. She is a senior lecturer, College of Medicine, University of Nigeria, in Suka, of course, and also a consultant radiologist at the University of Nigeria Teaching Hospital to Kozala here in Enugu State. It's good to have you on the show, ma'am.
Good to be here.
You're so pinky. You look, it's a pink thing. Cancer and pink go hand in hand. Oh, yeah. Somehow I decided to compliment the white part of the pink.
Sure.
You look so amazing.
Breast cancer is all about pink.
Yes. Good to have you on GYNA Plus. Thank you for coming.
I'm glad to be here.
It's not so easy having someone like you come here on a daily. Well, but I mean, it's such a privilege and honor to have you. Welcome.
It is my pleasure. Thank you.
Like I mentioned, October was the buzz was all around cancer awareness. While that actually happened, of course, being in the field, you know that this is not a one-off conversation. It shouldn't be a month thing. For us, it's something that is constant. But before we begin with all that happened, I'd like us to begin with the basic. When someone hears the word breast cancer, what is it that comes to mind? And then the next question that will follow is, how does it even develop? So just walk us through that a bit.
When people talk about cancer generally, it's like, I think the first thing that occurs to many people is this is a death sentence. So when you talk about breast cancer, it comes with a lot of emotions. I think maybe because it's mainly a female burden, or even though a very minute percentage of men may also develop breast cancer, it's not strictly only a women affair. That's what people don't often know. About 1% of men may develop, 1% of breast cancers may develop in men. And I don't want to go into the why that is so, because they always say, do the men have breasts? But yes, when we are all small, we all have a small part of breasts. The cells are there. But as the females develop and into puberty, their own develops and becomes the breast that we see. So that you don't see it in men doesn't mean that the cells are not there. And then when we're now talking about cancer and development, how does it develop? These are from cells. And that's why the men can have it. Because as long as you have those kind of cells, then cancer can occur if something goes wrong. Let me put it simply that cancer occurs when the normal cell will grow, some will die off, new ones will come up. This is a regular pattern in the body. It happens all through our life. We don't even feel it. How does the skin peel off? How do things change? How do people grow? Those are the functions of the cells. So what happens at the very minute level, we now have this abnormality that happens at the genetic level, if I may use those terminologies. I'm trying to make it simple, but at the genetic level, within those cells, something goes wrong, and a cell that naturally should die, all of a sudden now has this inability to die. and it keeps on growing and growing and multiplying. And then if it's cancerous, because it can grow and multiply, but it's not cancerous. A very common example, since we're talking about GYNA+, is fibroids. These are also abnormal cells that refuse to die, but they're not cancerous. So women don't have the problem we have in other things like breast cancer. But it keeps growing, and most often you may have to remove it. Fibroids, everybody is aware of fibroids, yes. So it's a neoplasm tumor, you know. But when it's not cancerous, so tumors can be benign or cancerous. So once it's cancerous, that means it now has the ability to spread to other parts of the body. And that's where breast cancer can start in the breast, and then it can now spread to other parts. And usually the spread is very detrimental to the human body. You know, it causes a lot of damage. And that's why people eventually die from it. So this is very latent how cancer develops. It's genetic abnormality. The cells are unable to die, and then they're able to spread beyond where it started and go to other organs.
I mean, that well said. I'd like us to be a bit more practical. We are in Enugu State, and this is your field, something you do, you attend to patients at different levels. Where would you say we are in terms of, you know, awareness, first of all, and then secondly, what are the numbers like? Do you think we are doing well? Enugu State we are saying that, oh, even though they say it might be one of the leading causes of cancer deaths in women, do you think we are just not there yet in terms of, oh, we are not that? Okay, in simple terms, so many women are not coming down with cancer. What is it like in the hospital? So in simple terms, what are the numbers like? I think that's just the long and short of this whole question.
Yes, so I may not have the exact figures. And you've asked several questions. Working in a tertiary hospital, we're like the last bus stop. So we tend to see much more women with cancers because like everybody refers to us. And like UNTH where I work in is a tertiary hospital which has full capacity to handle cancers of any form because we have all the modalities that are needed for treatment. We'll, you know, maybe later go into that. So when we're looking at that, with that background in mind, you see that we'll see on an average much more women with cancers than other hospitals may see because referrals come to us a lot. When you're not looking at the wide picture, awareness, we really haven't, I may say that where we were before, because I went into breast cancer awareness and maybe awareness of other cancers many years ago, as far back as the early 2000s when I got involved in some of these things. So the awareness has been poor, but I'm grateful to see that there is a change. It's gradually improving. People are becoming more aware, but a lot still needs to be done. Even with the awareness, there's a lot of denial. And women, you know, don't like showing up until very late. So we still have a lot of late presentation, which is one of the key problems that we have. Are we doing so well in terms of, you know, I think generally Nigeria has a huge gap to fill up generally. In Enugu State, we still have a lot. There are many places, remote areas where people are not even aware of these things. They come from the villages, huge masses, ulcers that shouldn't have been there if only they knew. So many factors, the church-based faiths, the herbal, you know, unorthodox and all that. There's so many factors that are working against this. But what I can tell you is that more and more people are going into trying to create awareness. Tell women what this is all about. Don't be afraid. Don't think it's a death sentence. Come out when we can really help you. And that's the basis. I
mean, I'm glad that you really put this out there. Before we talk about the screening activity that happened at the Medical Women's Center in Enugu, I mean, some weeks back. I mean, that was in October still. I'd like us to talk about the science. So you painted a picture of sometimes some of these people come down with so many cases and maybe present late because they probably do not know. What are like the first telltale signs? What should they look out for? I know oftentimes talk about do self-examination. When you see that one side is doing this, a tumor, there's a mold or whatever that language is, go to the hospital. It doesn't seem like we listen to that thing people talk about most of the time. But then again, for someone watching you right, a woman or perhaps a family watching us right now, what is that one thing that they should see and say, no, I shouldn't just take gloves or maybe treatment into my hands, I should rush to the hospital? The very small signs that we ignore.
Okay. So signs that may suggest that something is wrong, because the breast could have other things that are not just cancer. So it's not that every time you see something, it means cancer. But anytime you see anything unusual in your breast, you're supposed to look at your breast. So the skin, is there anything unusual? Is there a change in color? Because you should know the normal. And that's why we keep saying, do the self-examination so that you know what it is norm. It's not to find out an abnormality, but know what your breasts look like on a normal basis. Any day there's a little change, you can recognize it. So that's the importance. So if you see a change in the skin color, whether maybe one side, if there's an increase in your breast that you really can't explain, if your nipples used to be pointing outwards and all of a sudden they go inwards, of course, by the time you touch, are you feeling something that is a lump? And the touching or the examination should be done after your period. If you're a woman who is still seeing her period, after like you finished your period, and maybe give it a few days after when the breast is no longer very lumpy. So during period, it's lumpy. But once you're able to do an exam, maybe 3 or 4 days after your period has stopped, your regular period has stopped, fine. So if you feel a lump, very important. If you press the nipple and there's some discharge, what we call discharge, maybe a little fluid coming out, it could be like milk, it could be bloodish, it could be brownish, it could be clear, like water. Whatever you see, whatever color, just present to the hospital. Of course, then if some women now won't even know there's a lump, and then they now start seeing kind of an ulcer, what we call an ulcer, the skin is now eroding, and you can now see those changes, definitely, you just have to come to the hospital.
Wow, I mean, that was succinctly put and it's very clear. Maybe we'll talk more about it later on. But I mean, some days back, we were all at the Medical Women's Center. Dr. Brenda made sure we were on ground. So we were there to see the process, and lots of women came out. It's an annual thing for Enugu State Medical Women, free breast cancer screening and cervical screening, which is really very, very commendable. And you see women coming out in their numbers. So, but you were also on ground doing a lot on ground. I saw you too. Yes. So talk to us about that outcome. And do you think it's something that is making impact in terms of picking some of these, signs? Are there actual cases where you get to identify from this exercise? And just comment on the general turnout, then maybe we'll take a moment to listen to some of the women who spoke to us.
Okay, great. I really think it's something, I wish you could do it more often, and it doesn't have to only be in October. But, most of the limitations is funding. Of course. Because everything is all about the funds. So at the screening this year, in fact, we are always overbooked. We started with saying we're going to do 200. People said, okay, well, we can extend a bit more. Eventually, we had more than 350 women who registered and got a code. But on the ground, even that day we had more than 50 or almost 100 who had no code. So separate from those who had already had. So we are always overbooked, and it's a whole stretch. And then there was the cleanup exercise. So we started a bit later than we intended, but we still tried to do that. So yes, we offered every woman who came a form of cervical screening, which we call the visual inspection aids, as the VIA. And then we did clinical breast exam. So clinical breast exam is different from self-breast exam because this time around a medical practitioner who is well-trained is doing it. So we did that for every woman. And then when we did the clinical breast exam, every woman that had any kind of discharge, those things I mentioned, any serious history, we did the ultrasound. And that's where I came in as a radiologist. And our members, you talked about the team, the Bison. So we have our Breast Imaging Society of Nigeria. So the Enugu chapter, we came with other radiologists. We had this handheld device, which we thank those who donated it to medical women. So for the first time this year, we did it last year, but this time we had our own machine. Yeah. That's the difference. So last year, our radiologists came with theirs. This year, we came with that. From the M1 had their own at the center. And then we also supported with our own devices. So we had about 3 different scans. So, and we had...
all of that was for free?
Yes, and it was for free. And we scanned more than 35 or so women. And we were able to pick up 2 that we have to do a biopsy to know whether that's cancer or not. And we also found other things. Some we said, oh, don't worry about it, because there's a way we grade the findings. So there are some you see, don't bother about it. It's benign. Like I mentioned, benign, malignant. There are some we see, oh, it looks a bit suspicious. Let's follow you up and then maybe check again in a few months. And then some we see, no, definitely we have to do a biopsy. And we also do that. With ultrasound, we can comfortably take some kind of tissue, send it, and it confirms whether it's cancer or not. Wow. And we saw some Some women who had that.
Were they like middle-aged, advanced, or younger women?
So we had a young lady in her 20s, and then we had a middle-aged person, I think in her 40s or so. So in her 20s, positive, what we say, positive family history, the mom. So that really sent all the red flags.
We'll talk about that. I mean, thank you so much for putting it out there. I mean, if you just joined us, this is GYNA Plus. It's a very important discussion we're having. It's about cancer. And I mean, the outcome from the recent free cancer breast screening that was done by Medical Women's Association in the State chapter. We'll take a short break. And once we are back, our guest in the studio will also talk about, I mean, she mentioned that she saw a woman in her 20s. We had a sign that it could be cancerous cell. But then again, we'd like to know why that is happening, even though she mentioned that it's quite genetic, but there's so many other factors that could be, which is what she'll be telling us more after the break. Please stay tuned. There's a lot coming your way. We'll be back after the break. Welcome back. If you just joined us, you're still watching GYNA Plus on Afia TV. And of course, we're still talking about breast cancer. I still have Dr. Ngozi Dim right here in the studio. Before the break, you were talking about some of the outcome and observations you saw at the screening, the breast cancer screening that was organized by Medical Women's Association, where you mentioned that when I asked whether they were younger women who, you said the lady in her 20s too, you had to follow with that scan. So that brings me to my next question. For people who have maybe genetic history, like they have something within their lineage and it shows that maybe a parent or a relative had breast cancer in the past, how early would you advise that this kind of persons begin their screening? How, at what age, and are there kind of certain things that they should do to ensure that they don't come down with cancer too?
Well, okay. So screening is, when you talk about breast cancer screening, there are different screening, even though technically speaking, the more common screening is the one we talk about, mammography.
Okay.
But that has an age, because you usually apply that. It's a kind of radiological imaging that helps us to screen women who have no problem, no symptoms, with X-ray, a special kind of X-ray designed specifically to check the breast. So it's very specialized, very low dose. People worry about radiation, but that's not a worry. So, and then there are people, we use ultrasound when the woman is not up to that age. So in a young lady like the one I spoke about who had that history, when you say genetic, you have to now do some testing to confirm whether they actually have the gene. So it's not just because, a mom had you have a history that maybe the history is first degree relatives. That's what we talk about. So it has to be like a mother, the mother's sister, the grandmother, that's direct in a sense. But for you to say genetic, you would have done some genetic testing, and that's usually very expensive, not always available. But we have those recurring history, and that's already risk. Even if you don't do the genetic testing, with the recurring history of very close relatives, grandmother, mother, sister, or even a mother's sister, like sisters in a family, could also be, it's a positive history. So with that, if you're not up to 40 for the mammo, which is the ideal screening, because it has advantages of detecting things that you won't even know are there before you even start feeling lumps, before you start seeing signs. That's the advantage of mammo. But we could use ultrasound. We could also do an MRI in younger people, because unlike mammo, that doesn't have X-ray. But each of these things can be used for screening. But the ideal one is the mammo. So different situations make us use ultrasound, maybe because we can't do the mammo, or that the lady is still very young. When you're young, you have a lot on your breast, the normal tissue that covers those calcifications. That's what we look for on mammo. Calcific things, things that are calcified that help us. It's an early sign. But when the woman is still young, you can barely see that because of the normal breasts, the way the breast is. So everything depends on age, situation, availability, like MRI, not always available. If it's there, do they have the right equipment to use it for breast screening? But they are all possible to use. But we use mammo. That's much more from 40 up.
Yeah, I mean, the good thing is in the second part of this conversation, we're going to dwell more on this. Yes. But on a general sense now, I like the fact that you really clarified on this for people with history. But in a general sense of the word, for younger women, at what age is it recommended that if I have a daughter right now, what age should I open her up for screenings like this, especially for breast?
So if it's with those, these are what you call the high risk women. Those with positive history or other risk factors are high risk. So family history is a high risk. You would recommend these women learn self-breast exam as early. In fact, every woman should learn self-breast exam as early as they start having the breast.
I think we will do that before we end this show.
Yes.
Right here on set.
Exactly. And then now the clinical breast exam is something that you ask women to do yearly. So for such people, you have that increased awareness, start early to do clinical breast exam. You can use ultrasound if there's any need for, you can look at the breast. But like I said, ultrasound has its limits, but that's what you can use early stage. So you do clinical
from 20 years?
At any age. Ultrasound doesn't have any limit because it doesn't use radiation.
So once you have breast?
Yes, you can do that every year, do clinical breast exam, add ultrasound, and just follow up. And then if there is now a need to go for that, assuming the woman has a symptom or there's worry or there's something palpated and you can't do mammo, maybe in the 20s, you can go an MRI if it's available. So these are the options that we use for people who are much younger than mammo. If it's 40 years, maybe had children already and just about to be 40, you can go straight ahead and do the mammo and see and then combine it with ultrasound. To help screen. Yes.
Okay, as we plan to wrap up this particular, the first part of this conversation, the thing is, it's going to be a two-part series because there's a lot more that we've not talked about, and our time is almost ticking up. So let's talk about breast self-examination. I know oftentimes they tell us you have to take your hand up, and then can you just let's use just let me follow your cue, and then we try to see how that can happen. And for someone watching, so they know that this is where you touch. What if their lymph nodes? Should I be scared and all of that? So let's just do that very quickly, then we...
Okay, so self-breast exam, background first is that it's usually done if you're still seeing your period, a few days after your period has stopped. So let's say day 1, do it on day 8 if you have a 5-day period. That's an ideal time. 7, 8, 9 days, start doing it so that you can actually feel just the breast and not lumpy breast. And then preferably do it after you've had your bath because then your skin is moist. So if you're going to examine the left breast, use your right hand. Keep this up because when you raise your hand for that side you want to examine, it carries up the breast. So the ideal thing is first, look. Do I
have to be in front of a mirror?
Yes, preferably in front of a mirror. Yes, that's the best. So look, see if there's any difference in size as it has been before because every woman, most of them, the breast one is bigger than so you look for size. Look at the skin, look at the nipple. Remember those things I said? Then after the looking, you now place your hand and use the opposite hand. Put it flat out because where you're not going to use the tips. Yes, like you're going to use the back of your fingers, not the tip of the fingers. So you place that over the skin and imagine your breast into 4 quadrats. And then from 1 quadrat, just keep on palpating, that's the word we use, and go move it all around your breasts. Make sure you don't lift your fingers much because you're going to try to go over it without skipping any parts. And then when you're done, the 2 fingers hold the nipple and press around that darkened area, let me put it that way, and press to see if anything comes out. And you repeat the same thing for the other side. And then before, of course, you end any, go into the armpits and see if you can feel anything. You talked about lymph node. That's where you feel the lymph nodes if they're there. Sometimes women don't feel anything here. They feel something here.
And that means you should go to the hospital.
You should go to the hospital. So anytime you find anything unusual, please go to the hospital.
I mean, I hope that was really helpful because we talk about self-examination all the time, but sometimes I normally would think that it's not the tip. You would, use your tip and then I'll use your press.
It's not the tip.
All right.
That's important.
Thank you so much.
You're welcome.
Now, I know that as we want to wrap up this first part of the conversation, I'd like when you started, you said something that oftentimes when cancer is mentioned, people think it's a death sentence. And so a lot of people, it's not a discussion they want to ever talk about. You don't want to hear. The God forbid thing takes the center stage. But as we wrap up this conversation, what is one message of hope you'd like to give out to people listening to us now as to how they can live their life in terms of being available for discussions like this, opening up for screening? And should there be that, God forbid, of course, there's a cancerous cell found, how should they take that kind of news?
So I would like everybody to have this in mind that Cancers, yes, there are illnesses that we don't like, but if only we could be aware of what cancer is, how it starts, that awareness is so important. And then the things that we need to do, like the breast examination we talked about, the screening if you're up to age for any of those things. Once you're able to do them and catch this early, there is so much hope. There is so much hope. Early detection save lives, and that's our slogan all the way. Let fear not drive you away, and then you now come back when there's nothing we can do. Please come when we can do everything, and you can actually live, many more years.
Thank you so much, Doc. I mean, it's been a very informative and eye-opening session for me especially. So if you discover that there's some liquid, there's any fluid, you don't understand how your breast looks or works, please go to the hospital, not a chemist, of course, like we call it. Of course, we've been talking with Dr. Ngozi Dim, who is a senior lecturer, College of Medicine, University of Nigeria, and also a consultant radiologist at the University of Nigeria Teaching Hospital, Itukozala. It's been such a great time having her on set. But we have a part 2 of this conversation coming, so please do well to watch next week again. My name is Doris Mayum Shishe. Do have a lovely, lovely evening. Bye.